Okay, our next speaker is Dr. Penny Larcombe. She is an adolescent and young adult medicine specialist from the Gold Coast. She has pioneered the eating disorder and functional disorder services there, and she's here this afternoon to talk to us about functional disorders.
Thank you very much. It's really nice to attend this conference the first time I've come to Don't Forget the Bubbles, and I started working with Henry about a year ago in our new service at the Gold Coast. I do have a special interest in functional disorders and have been working in the space for quite some time now. I was reflecting on it. I started in 2017 just on my own with a psychologist who also had an interest in this area, and over the years we've managed to get permanent funding for a multidisciplinary outpatient service for functional disorders, and we're still learning along the way, and I really wanted to impart, I guess, some of that experience to you today, encourage you to think about how you look after young people with functional disorders in your space and what you can do, and also just to improve understanding, because I think that improves compassion, it improves care for this cohort. So functional somatic symptoms is a broader umbrella term that functional neurological disorder fits under. Functional somatic syndrome is a cluster of symptoms that can mimic or look like other organic disease, but when we do our history and examination and investigations, everything comes back normal, doesn't fit that pattern. And those symptoms impact the everyday function for that young person. It may be about mobility or persistent symptoms, affecting particularly for young people school attendance or being able even just to do everyday activities of daily living. In the research, there's over 30 labels for different types of functional disorders, which is really confusing, not only for patients and their families, but for doctors, for researchers, for coders. How do we capture these types of presentations? And it's also dangerous that perhaps clusters of symptoms can go down a certain treatment line where the underlying issues or what we think are contributors or causes of functional disorders aren't being addressed. I think a really good example is the term atypical chest pain. I think we use that fairly commonly in emergency departments. But what does actually that mean to the family? It doesn't certainly lend to perhaps looking at the psychological contributors, and also adds to the thing of, oh, I'm atypical, there's something perhaps that hasn't been found yet, something's been missed, and may lend to that ongoing presentation to emergency departments. Functional disorders tend to have a more prominent symptom that may be pain or maybe weakness, but often when you actually delve into the history, you'll find other functional symptoms like fatigue, autonomic symptoms. POTS is a big emerging topic, which could probably be a whole another talk. So when we talk about functional neurological disorder, I'm meaning those that mimic neurological type conditions like seizures, functional gait, tremor, functional weakness, and dissociations of periods of seemingly loss of consciousness. This isn't new. There's been, again, lots of different terminology in this space as we become to understand this disorder. Hysteria, shell shock, previously known in the DSM-5 conversion disorder. For a couple of years they were using medically unexplained symptoms. Wow, how to reduce the stress, right? It's unexplained, good luck. So certainly it is very confusing out there. But what is FND today? We really understand it as a neuropsychiatric disorder, and I am going to talk about neuropathophysiology, I'm sorry, but I think it's actually really, really helpful, and it's a really smart audience here. So, what do we think? We know that young people experiencing functional disorders are carrying a significant amount of physical and emotional stress that leads to excessive activation of our brain stress systems. And now this gets a bit complicated, but hold on, please. One of the big things is salience detection. So what I mean by that is how we are vigilant in our environment to threat. So what's different gives it, I guess, when we're walking along that dark alley at night time, our salience detection systems is on the go. Very important protective factor. Our arousal systems, our readiness for action, to fight and flight, and our emotional systems. These are highly upregulated in functional disorders, and also very overly connected to supplementary motor systems, our sensory systems and our pain systems. So there's a really strong connection between these parts of the brain. Again, don't get too distressed. This is some pictorial representation of functional MRI. But what I guess I want you to take away is that there's a lot going on in the brain, and I think that picture up on the right there, the difference between feigned paralysis versus functional paralysis is completely different. And I guess that, sometimes you have these feelings, is this factitious? Is there something going on? It's actually very different what's happening in the brain compared to a factitious type presentation, which is a lot rarer. In the research, there's some evidence around some of the neural pathways in the context of what we call agency, which is our voluntary or conscious control over movement in connection to our sensory feedback. So what actually is happening for us in our body. And what we see in functional disorders is that a person has stronger predictions about their ability in voluntary movement around ideas about weakness or tremor or functional gait. And with increased bodily awareness, this overrides the feedback or sensory feedback that actually everything is working okay. In the research with those with functional disorders, when they recalled previous traumatic events on functional MRI, these stress parts of the brain, these neural pathways, were in a dose effect more increased in the context with those motor systems. So a really strong connection. So who gets FND? Certainly we know adverse life experiences can increase your risk. And so certainly when we think about the ACEs and increasing, we know in the science around epigenetic and genetic changes. So they're certainly seeing polymorphisms in particular genes in association with functional neurological disorders. But also we see neurodevelopmental changes again in these neural pathways are more upregulated in a dose effect with your previous adverse life experiences. We certainly see an association with anxiety and depression. And interestingly, alexithymia, which is what we call emotional blindness. So we actually see it's a neuropsychological phenomenon where people have trouble recognising, expressing, and describing emotions. And this is often the context of issues with early attachment in their families and their mother, and difficulties in interpersonal relationships. So they don't even actually recognise the stressed. It's just not even there, or even in the vocabulary. We certainly see in functional disorders, those have heightened body attentional focus. And I guess I can reflect on a couple of cases where there's been a physical stressor that's led to a functional presentation, like head injury. I've had a couple of AFL players who had a head knock and then presenting with functional seizures. So really attending to those bodily symptoms. You don't necessarily have to have a traumatic event to have a functional disorder. Significant natural life stresses and experiences that are traumatic enough in one setting can lend to a functional disorder. Certainly in my space and working with young people in the paediatric population, we see in the research and certainly in experience in doing the assessments in these families two particular attachment categories, represented in over 90% of the cases. So one group is the avoidant attachment strategy, and these are the good kids. These are, you come to the emergency department and you say, I think this is functional, it's related to stress, and the families go, my child's not stressed. They're a good child. They don't complain. They're getting A's, straight A's, school captain, whatever. No, this can't be a problem. They're not stressed. But often stress is not tolerated in the family, so that you carry on, you trudge on. In all adversity, you don't complain because you've got it good. You're doing all right. The other type of attachment strategy is the anxious of ambivalent attachment strategy, where there's a bit more chaos within the family. Sometimes there can be explosions within the family. Sometimes it's not tolerated. It's just not consistent. And often the young person may be carrying a simmering anger, but it's just not, I guess, allowed to be expressed within the family. Maybe violence, maternal mental health, for whatever reasons, emotions can't be really expressed consistently in the family setup. So what it comes back to is functional neurological disorder is a stress disorder. The stress doesn't have anywhere to go. So the young person may be in a situation that they can't change. It might be significant domestic violence. It might be that they don't recognise the stress, they have trouble even relating to it. or they can't express the stress because it can't be heard, it can't be tolerated within the family. What happens is it starts to build up and the brain alarm systems start to go off, and we get symptoms like pain, fatigue, the neurological type presentations in the motor system, and we even see increased inflammatory markers in this cohort. We know about the mind-body interface. It's not new. I think, when we're managing a stressful period at work, we feel fatigued. We can totally acknowledge the context of stress on our body. I felt a bit nauseous getting up here today. I'm a bit stressed right now. Stress headache, we talk about that. Panic attacks, I think this is a great example of how stress affects the body, and I think it's a great way to talk to families about it. It comes on without control. The person doesn't just put on a panic attack. It's not voluntary. They are significant physical symptoms that affect lots of different systems of the body. And you can learn ways to control it. You can learn ways to reduce the number of panic attacks and actually work to get through that. Tonic immobility. I'm sure you've seen some cool YouTube videos. I should have put one up, like the goat falling over with a significant fright, or the gazelle on the savannah and the lions, taking it down and it's gone totally immobile. I think about that in dissociation. These are reflexes within our body. I love broken heart syndrome. I don't know if you've heard about this one. Some Japanese name, Takotsubo or something like that, where in the context of significant grief, you get a cardiomyopathy. It's sudden, it's temporary, loss of muscle, cardiac muscle weakness, and it can lead to significant events in the context of a significant emotional distress. I think that's amazing. Another good way to conceptualise this with families is how we manage stresses and how it accumulates in our bodies is putting it on a bit of like a timeline, and I put stress up on one axis and time on the other. And certainly across the course of the day, we have degrees of anxiety or worry. Mine's up a little bit now. When I get on the plane and have a glass of wine, it'll be a bit down. But as it accumulates, things that happen along my life course or over a stressful time, panic symptoms can start to emerge. And then as this accumulates, becomes really chronic, functional symptoms can occur. And often when you ask a young person about panic, those symptoms have been there, may not just have been recognised as panic, especially with a somatic body focus. So when I talk to young people, I talk about the stress bucket, and our body is a bucket of stress, and we have varying degrees of how much it's filled, but it might be just a little trigger that suddenly the bucket's over, it's pouring over. So it might have been even just an illness, significant illness, or a terrible exam at school, whatever. It wasn't a major thing, it wasn't a massive trauma, but suddenly I've got functional symptoms. But there's lots of things that are underlying all of that. And then having a way that we might manage that, and having the tap of the bucket where we can start to offload those stresses. So there might be actually sorting out some of these problems, but also coping strategies in the context of things that we can't sort out, and how do we manage stress in a healthy way? How do we externalise this stress and get it out of the body? I want to quickly talk about a bit of a process in therapy and how we do this, and acknowledge that I now have a lovely multidisciplinary service, but there are elements that I think you can take away and think about how you use this locally. A prompt diagnosis is really important. We want to stop that excessive use of emergency departments and have a quick follow-up in a better outpatient setting. We want to do a biopsychosocial assessment of the child and the family so that you can actually personalise this and talk about what are the stresses in their child's bucket. Providing a feedback to the family and in construction with a mind-body sort of approach, and then developing a personalised treatment plan and implementing those interventions. In my service, we want to hear a story of the presentation. So a timeline is a great way to do this, and a lot of psychologists use timelines for different other things, but this is very helpful. And I do it right from pregnancy and birth through to the presentation. And it maps out the medical and physical aspects of what's happened in that child's life, but what have been the things that have gone alongside that? What have been the social changes and developmental changes, and how that impacted the family? And we also do a 3-generation genogram where we look at not only the medical history and the mental health history within the family, but also important relationships. How are problems managed within the family? Who does that young person go to when they have a problem? How is the parent parented this comes back to this idea of how do problems sorted within the family, how do we talk about problems with our family. And by this time, I don't have to say anything, all the light bulbs are going off for the family just by putting it up on a board and working that through. Again, this is just an example of perhaps how we think about this. This is one of my patients, but who had a rheumatological condition, who had a functional weakness and had sleep disturbances and feelings of anger and guilt towards his Japanese parents who never talked about any problems. So just a way to kind of put all this all together. And this is how we feed it back to the family. Again, the details aren't important up here, but we want to look at what were the predisposing factors, what are the styles within the family, what precipitated these events, and these can be physical and mental precipitants. And then what keeps it going, because then that helps us target what we're going to do in treatment. And also with our strengths-based approach, we want to look at what are the protective factors, what is going to help this young person and their family recover. It's a systems level approach to treatment. The young person in the middle, with the support of their family, understanding what's going on, helping them talk about stresses, making sure you manage any persistent medical worries, stress regulation. We really want to help them return to function. We do a really rehabilitation type approach and return to school with the support of a multidisciplinary team. And we really want to promote self-management, because stresses don't go away in the lifespan, but how can we manage this over the course of time? Again, this is just an idea of a treatment plan. The details are not important, but when we looked at the perpetuating factors, we can think about what the interventions are that go along with that. Establishing healthy routines and sleep is a number one priority, and then tackling particular problems that might be happening with the family, thinking about psychological strategies, school interventions, and focusing on any previous traumas. Positive diagnosis is a tool that you can all use in your emergency departments. What I want to say to you is, when you think about it, if you've come at you thinking about a functional disorder in a presentation, I want you to say it to the young person and the family as part of your differential right from the start, even though you've still got a few things you need to investigate. Because what the worst thing is that a diagnosis of an exclusion doesn't build confidence within the family. It's like you've done nothing, oh, now it's a functional disorder. So the families don't have enough confidence in that. So if you put it right there from the get-go in your thinking, it's more acceptable. I want you to do a good, thorough physical examination because, again, the power of the doctor doing the neurological examination and even showing the inconsistencies and why you don't think it's a stroke and why you don't think it's a spinal lesion are very helpful in the families, making sure that they feel like they've had a good medical think. And sometimes you do need to get another specialist to come and provide that second opinion to help the family feel confident, whether that's depending on the presenting symptom, of course. By the time families get to me, they often report feeling offended or dismissed by the medical system, stigmatised and angry. And when I talk to my clinicians, and we do lots of education down in ED and in the paediatric department, is that clinicians feel helpless, out of their depth, don't know how to talk about these things, and feel overwhelmed. I'm hoping that by you understanding the pathophysiology might lend to you feeling more comfortable talking about this, because there are things happening in the brain. It is medical. Language is very important, and the feedback from families is that using the term pseudo-psychological behaviour are often misinterpreted, even though our intentions are good, and actually leads to therapeutic rupture. Normalising the disorder. So I'm hoping you can use things like dysregulation within the nervous system. That's a big lot of words, isn't it? Activation of the stress system and disruption of normal motor function. Mind-body interventions restore functioning. So families love it when you talk medical to them, because that's what they feel comfortable about. They don't want to talk about the psychological stuff. But if you can say, this is a stress disorder, but we see these changes in the brain, this is out of control of your child, can really lend to opening the conversation. Being compassionate, thinking about, again, spending some time with that family, not, it's a functional disorder and walking away, it's a functional seizure, walking away. And they're like, what's going on? And then thinking about pathways, because I guess we want to reduce acute hospital utilisation. Who can they see? Who in your area perhaps has an interest or has a wish, or just wants to, start to do some work in this area, who you can refer to. Very lastly, I really want to talk about a bit of FND, first aid in the emergency department. I just want to say it's really important to spend some time taking a good, thorough history, ask about those other functional symptoms that may not even be on the parents' awareness, like panic symptoms and other things like that. Often they're there, they just haven't been asked about. Do a good physical examination, have a good consideration of medical investigations, and be, as you normally are. You're not going to do a whole lot of things you don't think are necessary, but do what you think is pertinent within your, differentials. What I wanted to say is, if functional disorder has been discussed already in the family, and you're getting that sense of we don't want to talk about that, I think really become curious and really talk about what has been the experience or their understanding of those discussions previously. I think if we can say, oh, you've heard about a functional, what did you understand a functional disorder to be? Because often it's one of two things. One, they feel like their child's done something wrong, that's all in their head, that they're faking it. So that gives you an opportunity to address that. Or there's still a persistent medical worry, and that they are still really worried this is epilepsy, or there's a lesion on the spine. And you're going to have to think again, how can we address that worry in a safe, reducing age-related harm, but getting investigations done that help that family move forward. And then again, thinking about making sure they don't feel dismissed and left without a plan when they leave the department. So I hope that you can take something away today that will help you in those situations, and thinking about, with that understanding of the pathophysiology, how you can support young people with functional disorders. Thank you.
Thank you, Penny. Time and again, this theme of language comes up, doesn't it? And how it's so important for us to be thoughtful with the language that we use when we're communicating with families. Any questions for Penny?
One over here.
One over there.
Thanks for that. That was really helpful. Is there any consideration of the importance of some kind of family-based therapy as well, given that these kids are not an island, they're within a family, and obviously this is an intergenerational issue with mental health concerns throughout?
Yeah, absolutely. We, in our assessments, bring up a lot of family or parental issues, and I think my next big wish is to have a family therapist within my clinic. But we do support, we provide that feedback, and that might be a family or parent-only session, and then look to find support within the community for them, whether that's individual work or looking for community-based family therapists, which is very hard, certainly in my area. But it's surprising when we do this non-judgmental assessment and look at the family setups, how much the families can actually understand that and take on those recommendations.
There are two questions over here, so I'll come to you in a sec.
Excuse the ignorance of this question, but at the beginning you showed the functional MRI images difference between factitious and functional disorder. From a diagnostic point of view, what points you towards factitious versus functional? Like right at the very beginning, how do you differentiate? Because I assume it must be, I certainly find it very difficult. I don't know if you've got top tips.
What I would like to say about this is that I don't think it's something you need to prove in the beginning. It comes out with time. And so I think in the emergency department, it doesn't matter, even if someone that is feigning it, there's something going on for that person, and that needs to be understood. And I think often in the context of doing that assessment, that becomes clearer. I've had one young person who had she had functional weakness, but we were a bit stuck with her, and often I've seen, particularly in functional weakness, and again, this is not I guess confirmed in research, but just I guess a number of cases that when we're not making progress in physio and other things like that, that something hasn't come out in the assessment, and that's something that they're holding on to or haven't been able to express. And like for example, I had one young man who had gender dysphoria, and once I was able to get to that, started walking the next day and having talked about that. But in this case, I said, oh look, I actually fed that back to her. I said, oh look, we're really struggling. Just wondering, sometimes we find that young people are holding on to things And she came back the next week and she said, I thought about it and I'm faking it. It was really, and it was just like, I was like, oh, thank you for your honesty and what's going on. But I guess that's probably pretty rare. But I think maybe it was that permission to, maybe she felt there was permission to talk about that. But the only, I think factitious is pretty rare, and Munchausen's and Munchausen by proxy is there, but we see certain then difficulties in recovery. Secondary illness behaviour again it's different from factitious. There may be secondary gains or enmeshment and other things like that. Again, that's a whole nother talk. But certainly trying to help that young person individuate from that situation, find what is going on for them can lend to recovery, whether it's factitious or functional. And so I think you don't need to try and work that out in the front line.
And just because I'm a general paediatrician as well, so I see them chronically as well as in ED.
Yeah.
Just to clarify in my head, does that mean in terms of thinking about functional, we're thinking about it, like you say, as a stress or panic disorder, and that factitious is a different emotion driving
yes.
the behaviour?
So,
would that be the best way to
correct.
differentiate it?
So you often may see an antisocial type personality or trait, particular gains that might be met above and beyond. We do know that a functional disorder, part of those perpetuating factors, maybe secondary gain, and as we see, attention paid. The families cannot talk about stress, but they can talk about a medical problem. So that brings the family in, and so it sometimes can be a bit hard to tease that out. But I don't think you need to. I think you just need to support whatever is going on for that person and those factors that you can, broader factors that you can identify. And unless it's really induced illness, which it increases and becomes different, and I think it evolves over time, and symptoms become, to meet the need, whatever factitious or induced illness behaviour does, it often evolves to something more significant, and your alarm bells will be alarming off. But I often find in the functional space, once the family get it, they understand it and they feel comfortable, that the majority, and this is in the evidence and the research, the majority of young people recover. It's very different from the adult cohort, and that it's only 2-3% of functional presentations that become chronic in the adolescent space.
Thank you. One more question, if it's quick, no pressure.
I hope so. That will depend on the answer. I'm Ellen. I'm an emergency physician, and I often see people with FND, and particularly in adult land, the disposition is very often a very challenging question in the emergency department. I know that paediatricians have a lower threshold to admit these people, but what would be your criteria to admit a patient as an inpatient for multidisciplinary output? Often these people obviously don't immediately resolve with their symptoms, even though they may have been spoken to appropriately.
Yeah. It'll be dependent on your service, of course. In my service, if we cannot support that person to go home, I guess, again, I'm lucky in my service, we use our hospital in the home service for our functional weakness kids, so they get physio at home. And in my service, we're going up to age 20 now, so we are entering the young adult space, and we'll see them when they're admitted onto the adult wards, and again are looking for a hospital in the home model and using physio to try and get them out of hostile environments, because it is not conducive to recovery. It is difficult, I acknowledge, but there is an increasing interest in the adult space, and certainly I'm part of a national FND consortium that is looking at treatment programs for not only young people but for adults with FND. And what we're thinking is going to be like what's happened in the chronic pain space, that we would expect there will probably be functional multidisciplinary clinics across the country in about 10 years' time, once we finally get the data, trying to collect the data and actually show a case for the need for particular treatment in this space. But I think if they can't walk and they can't actually manage their activities of daily living, I think you're at a point where you need to admit them and really work with that person to understand and what's going on, that positive diagnosis, and then trying to work within the resources of your system with a really rehab type approach. And what's happening often in the adult space is the rehab physicians are taking this cohort on, and it's a rehab type approach, but unpacking what are the stresses within for that particular person as well. I hope that answers the question. It's a bit hard.
Thank you. Big thank you to Penny. So I'm taking away tons from this session, and I'm sure I'm not the only one. So let's just say one more huge thank you to Henry, to Simon, and to Penny.